Next, we're going to meet two people who have their fingers on the pulse of why healthcare costs are rising and what it means for the people and what their options are that are available. And we'll just make a note that we're going to have time for your questions after each session, so don't be shy. With that, I want to welcome to the stage Shannon Brownlee. She's Executive Vice President at the Lown Institute, and David Newman leads the HealthCare Cost Institute. And they are joined by my colleague, Washington Editor-at-Large, Steve Clemons.
Hello, good morning, everybody. Good morning.
You're on.
Hello, thank you very much for joining us. Get this all set up here. Thank you all very much for joining us. We're going to talk about all the nuts and bolts of healthcare costs, institutional change, and adaptation. Shannon Brownlee, if I could just say a word about her, is one of the people I truly respect. I like you too, but Shannon is a colleague of mine from way, way back when I was one of the people that helped set up the New America Foundation in Washington, D.C. And Shannon Brownlee came in at that time, way before it was a fashion and fad to do so, and began saying, our healthcare system just sucks. And just laid it out, and was a fellow that we funded to sort of think through things, and wrote what I thought was a really groundbreaking book called Overtreated, Why Too Much Medicine is Making Us Sicker and Poorer. She won the Science Writers Prize, the National Science Writers Prize that year, and has been someone that said, you know, we have today an ability with data, an ability with empiricism, of looking at results, of being smarter about these issues. But I just want to put a marker that she was doing that way back when. It turns out that my other new friend, David Newman, Executive Director of the HealthCare Cost Institute, was doing the same thing more surreptitiously at the same time, working at the Congressional Research Service, and there you can't take credit for anything. So that probably got to him, which is why you went private and public. So David Newman here with the HealthCare Cost Institute. It's great to have you both here. But let me just start out with you, Shannon, and ask you, as you see big healthcare systems adapting to the Affordable Care Act, the change that are going on there, what do you think is happening within the world of costs and transparency, and is it where it should be?
Well, one of the things David and I were talking about before we came on stage was the sort of confusion in the terminology. So let's use the same words. There's price, there's cost, which is sometimes used as cost to the consumer, sometimes used as cost to the hospital, and then there's spending. So why is spending not being very well controlled? We saw a little dip in national spending during the recession. It may or may not be going back up at the same rate that it was before. There are a lot of reactions to the ACA, but one of them that's been very important is consolidation of hospital systems. And hospitals are rapidly consolidating in many communities, which...
So is that good or bad?
Well, the problem is it depends. And for many places, it means closing safety net hospitals, which are serving the poor and underserved who really need access. And it also means rising prices in other places. So because of capturing market share.
David, you've gone into this business and have now set up, as I understand it, a kind of giant Wizard of Oz factory where you see
Correct.
Everything. You've gotten everyone to give you your data except Blue Cross Blue Shield.
Correct.
Are you working on them?
I've tried.
Yeah, so you've gotten everyone else to give you their data. And how did you get them to give you their data? Why would they trust you?
Well, basically, their interest is to understand better what's driving cost and utilization trends in the United States. And each company has their little look at their line of business. And many of these companies historically don't really worry about even their entire line of business. The data is controlled by actuaries in these companies, and the actuaries are concerned historically about the profitability of contracts and lines of business. One of our data contributors, our head of IT, literally fell onto his knees and said, "Thank you. This is the first time we've ever built a company-wide data set." And then they delivered it to us inside the company. So historically, and this is changing. It's changing in the insurers. The insurers understand that there's greater interest in population health within a community. They're taking on broader interest in terms of how do you create health. And we've been the third-party beneficiary of those interests.
And where is that going when you now do see all of the trends, and you've probably got more data? Just it must be better even than anybody else that's looking at that. What do you see? Is it a dark picture? Is it a great picture?
We hold 15 billion claim lines from 4 of the national carriers for all 50 states. Tomorrow, this comes out as our 2014.
What's it called?
It's our 2014 Healthcare Cost and Utilization Report. It's based on an analysis of all of the 2014 data.
Is that this paper that says confidential, do not share?
Yes, it is.
Got it.
And basically what we've seen for year on year since we issued the first report in 2010 is that, to paraphrase the earlier election, it's the price is stupid. As Shannon was suggesting, and my mother used to tell me, mind your P's and Q's. It's prices and quantity. And what's happening in this country is rising prices. We see about a 3.4% increase in spend year on year in our data. I did pull out prices and utilization for New Jersey. Mm-hmm. This is probably the first time we've reported publicly any sort of state numbers. But prices in New Jersey, we compared prices for about 240 services in New Jersey off of our Guru website. If you go to Guru, it's our price transparency website. And compared it to our national numbers. And 80% of the prices in New Jersey are at or below 1.2 times the national average. So you don't have a price problem in New Jersey. 60% of them are at or below the national average. What you have is high utilization. So it's price times utilization of services that create spend. And in our data set, excluding the Blue Cross Blue Shield data, you rank about 5th in the country in terms of total per capita spend.
Can I ask the audience a question? How many of you are healthcare professionals, physicians, nurses? And how many of you are still seeing patients, of those who raised their hands? So there's still a few practicing physicians in the group. I'm always curious as to how audiences see this issue of utilization. How many think that it is largely because of poor health in, say, the state of New Jersey, where you certainly have pockets of very poor
Among
health?
the people seeing patients still?
No, among everybody. How many think it's really, this utilization is really driven by poor health? It's partly driven by poor health, absolutely, but it's also driven by the patterns of care, and New Jersey has a very high utilizing pattern of care.
So can you put that in human terms for somebody who's not a healthcare professional? I have no idea what you just said.
So if you're very sick with multiple chronic illnesses, and say you're elderly, you're frail, you've got lots of things going on, you are likely to be hospitalized multiple times, and you're likely to see multiple specialists and get lots of tests and get lots of minor procedures. There's not a whole lot of difference.
Lots of back and forth. There's a lot
of going into the hospital, and what you're not getting.
You're not outpatient. You're not at home.
You're not getting home-based care. You're not getting community-based care, and you're not getting good primary care. You're getting the sort of highest, most technological care possible. And so the question really is this resulting in better outcomes? And it's not
So I
clear.
guess the question is, in your data set, which state, if you can announce that today, has the least utilization?
I don't know the answer. I'd have to look at this, but
We can say it's
We
for
can say it.
Medicare,
Yeah.
but I don't know from
Okay.
the private pay point of
What
view.
would it be for Medicare?
For Medicare, it's pockets. It's individual markets, really. So Seattle is very low. Salt Lake City is very low. All of Minnesota is very low. There are these places where the healthcare system behaves very, very differently. Northern California is very low.
So the whole behavioral norms around healthcare are different in these various pockets.
Right.
And New Jersey, because that was one of my questions, is what makes New Jersey different?
It's got a lot of beds, got a lot of ICU units, got a lot of specialists. We've invested in infrastructure that is very much technology-based, hospital-based, specialist-based, and not invested in the kind of infrastructure that you need to do really good primary care, to do really good community-based care.
in our data, what we find is high admits and high utilization of professional services, lower rates, below average on RX spend and on outpatient. So yeah, you can identify. And to take up on Shannon's point, we know that 50% of the spend is on 5% of the population. And focusing on those folks, getting them into systems of care is what's key.
So when you have all of this data, and it's much more transparent, not only to the consumer, but to the business folks behind the scenes in medicine, what are you beginning to see around the country? Because even here and elsewhere, we're seeing controversies arise over winners and losers of high speed, low speed. I was in Madison, Wisconsin the other day, and you basically saw transparency in what certain things cost that were different dramatically across town. And that looks like a lot of tumult to me and churn. Are you seeing that all across the United States?
Yeah, well, basically,
people hate you?
everyone's savings at the system level is a reduction in someone's income. And
Say that one more time.
every systemic saving that we achieve is a reduction in somebody's income.
One man's waste is another man's income stream.
Porsche payment or something else, exactly. And then we have some systemic reforms. The Affordable Care Act encouraged through the Medicare Shared Savings Program the creation of accountable care organizations. Economists, they're referred to as ACOs. Economists call them anti-competitive organizations as opposed to accountable care organizations. So you've had a lot of consolidation. I think the economists would argue that the consolidation has increased prices at the hospital level and had no measurable change in quality delivered. I think that's the general conclusion of the economists. You're now seeing massive consolidation around hospitals of buying physician practices up through the shared savings program. Every time that one person's responsible for saving $1, then there's a fight over the allocation of that saving. You can save dollars very readily by keeping people out of the hospital, but the hospitals need a certain amount of fixed revenue to stay in business. And here in New Jersey, after I gave a presentation at the Business Association, two women from the safety net hospitals came up and said, "You're going to put us out of business with price transparency," because their hope is that Bill Gates has a car accident at the front door so that they can gouge him. They don't want price transparency. So everyone is facing greater scrutiny on their costs, stiffer negotiations, and there's a lot of stress in the system.
This woman over here, third in, raised the question, said the reason costs were higher was because of the health of patients. Remember, you were the only hand up, and so I wanted to acknowledge that. Is there a trade-off where the race to become more efficient, financially less expensive to control, whether it's costs or spending, as Shannon laid out, does that lead to undermining health at some level? I mean, because this is the sort of converse of what Shannon has talked about, that certain times you need treatment, you need care, and you can be driving in a direction where you end up undermining the health of individuals and communities.
Well, look, there's another name for that. It's called rationing. And rationing means I'm going to deny you something, and we have to be really clear about what we mean by this, because it's thrown around as if, any time you say no to somebody, it's rationing. Rationing is when you say, no, you can't have something that would be potentially beneficial to you because it's too high-priced, it's too expensive, you're too old, whatever. Now, in this country, we ration care all the time, and we ration it on the basis of your ability to pay. So even though I wrote about overuse and overtreatment, we have a massive problem of lack of access in this country. And if we think that the market, the free market, is going to create open access and a great system that will provide the best health care to increase the health of the population, we're dreaming, because we don't make sure that people really have access. So, yes, there is a danger if
How do we fix that?
Well, I think, for one thing, we have to actually think of healthcare as a common good instead of just another business. I mean, I think that other countries, other high-income countries, generally see healthcare as a right and as a common good, because the health of the population is a common good. Because if you have a healthy population, you have a working population, a productive population. But we haven't done it that way. So that's a large-scale change. That's an attitude change, it's a regulatory change, it's a legislative change, it's huge.
So you've written critically, Shannon, of, I don't know what to call them, but these pop-up docs at like CVS and others, and ways to reach this sort of a highly distributed services that are impersonal, and you surprisingly, because I've known you for a long time, are trying to raise the human part of this question.
Yes.
I'm always sort of the anti-human. I want to pay respect to the gentleman back here who still sees patients. I don't know why robots aren't doing it, and that we aren't automating a lot of this, because part of the problem with the healthcare industry is inconsistency, right? It's misdiagnosis. I was reading, you have a staggering amount of misdiagnosis in the healthcare system. So for me, I sort of feel I'm much more comfortable with a lot more automation, a lot less of that human error, but you say that's an important part of it.
It's an incredibly important part of it.
So talk me down.
So human beings, health of an individual is this very complex process, and we have sort of started to think of medicine and health as being this very mechanistic, technical process. But in fact, human beings are their psychology. And we also, their bodies, their habits, many things go into our health. And one of the things that we have not acknowledged in the United States is how much of our health is really driven by what are called socioeconomic determinants. It's, do you have a good job? Do you have access to good food? Is it safe for you to walk in your neighborhood? Do you get good education? Those things are far more powerful than healthcare. So that is a piece of it, but that relationship with a physician is also very important. And you can think that a robot can do it, in part because, I don't know, Steve, but I doubt you've ever been really, really sick.
Oh, well.
And when you are really sick, you are a very vulnerable human being. So that's a big piece of it. But going back to this other question about sort of how do we get to a better system, I think we have to start investing in these socioeconomic determinants. And that is going to require extracting some of the wealth out of this highly hospital-based system and getting it back into communities. So when we ask the question of who should keep the money when we save it, well, I know there are lots of people who want to keep it all because there's a lot of waste to be kept. But in fact, communities, I think, should get to keep some of it. And taxpayers should get to decide where some of it goes, which is, I would think, back into better health in the community and better attention to these other things.
Which is why we're seeing more approach on wellness programs. And
which I hate to say don't work very well.
They don't work very well.
No, there's no evidence that these wellness programs really create much wellness or much savings.
So tell us how to fix it. What would you do differently?
I would invest in primary care
you're such
for
a combination
starters.
of optimism and
I know. I'm actually incredibly optimistic, crazily.
Yeah.
I would invest in primary care and community-based care. And the question is, how are we going to do that? How are we going to take that money and be able to invest in that? I think health insurers have a huge role to play, and I can't quite understand why they haven't yet really invested in primary care. So in Massachusetts right now, there's something called the Alternative Quality Contract, which is this imposition of a whole series of quality metrics on primary care that are supposed to improve care. Most of them have no bearing on health, and they create a huge amount of work for primary care doctors. They are anxiety-provoking for the doctors. They take a lot of time, and insurers are still not saying to primary care doctors, we're going to pay you enough for you to really create the infrastructure within your practice to really take care of your sickest patients.
David, what would be your formula?
You need multiple tracks.
Yes.
There is a primary care track. There is also a hospital track. There are people that need to be hospitalized. In some places, people, and there's been studies on this, mixed evidence, but that people die when hospitals close. Some people belong in the hospital. We've certainly reduced the length of stays dramatically in this country over the last 30 years. We probably the lowest length of stays of any developed country in the world.
But people then end up coming back and coming back.
High intensity, yeah. When they're there, you also need, I'll use the word broadly, but integrated delivery systems, whether it's a medical home model like Horizon's using, people who are truly sick need to be in a system where their care is coordinated in some fashion. That's the only way they're going to get well. They can't be expected to wake up in the morning sick, one of those 5% who's spending 50% of the dollars, and expect to navigate the system on their own and get well. So you've got to sort of parse out what these groups of populations are. The elderly is one group, elderly sick is one group, people with chronic conditions is a group. And then you've got folks who, and it's probably many of us in this room, who are basically walking well, who need a very different system of care that doesn't involve going to a doctor, trying to stay out of an expensive, once they're brought into it, a very expensive mode of delivery, because that's how the system delivers care. They need to be bypassed into another system.
Let me ask you just about the trend in these wellness programs, which Shannon said aren't working very well. But there sort of seems to be a nexus to me in this question of interaction or utilization and literacy of the patients that need services and support, how they think of their own health, whether a lot of the apps and the technology that we're seeing evolve, there are 250,000 some apps in the healthcare space, whether or not there are new opportunities evolving that help us, one, become more literate about health and what our expectations should be and how to sort out. Because I have to tell you, I'm not very literate.
We reached this conclusion pretty quickly earlier today, if I can paraphrase it, which is don't bet the barn or the farm on consumer engagement. You know, that is, whether it's wellness, whether it's price transparency, whether it is managing your own care, skin in the game, wherever you want.
Yeah, but
that is a lot of window dressing around that. And there's some evidence that suggests an engaged patient has a better outcome. But in terms of really controlling costs, bringing down care, improving things, I sat in a hospital bed one day, and they're giving me what I thought was the nitroglycerin after the chest pains, and my blood pressure's dropping and dropping and dropping. And finally, my wife said to them, stop. I'm not an engaged patient. I don't have that expertise. I want somebody to deliver my care. I have better things to spend and invest my time in than being an informed consumer. As I move into retirement, and many of the old, you're not going to want to manage your health care, you're not going to want to manage your retirement scheme, you're not going to want to manage all of these things. We want a simpler system that works for us. And that's what the system's got to deliver for us.
So you're not a big fan of the Fitbit and wearables craze?
I don't have one, my wife does. But
I mean, I run
a Fitbit. Let me open up the floor to questions and comments from those of you here. First comment, question? Yes, right here in the front. We're going to bring you the microphone. Here we go. We have millions.
Oh, can you identify yourself?
We have millions of watching online.
Now you've intimidated me by making me stand up. Could you comment on whether health care should be a right in this country or not? As I understand it, currently, there's no constitutional right to health care.
Thank you.
You're right. I don't know whether it's should be written into an amendment in the Constitution, but let's have a show of hands. Is health care a right, or is it a privilege? Right?
Right. Yeah.
Privilege.
Yeah. Both.
And there's differences of opinions. Yeah.
I'll give you a slightly different answer, which is, as a lawyer, I've looked at where rights come from. I've always been interested in this question. And you look to the Constitution, you look to where rights can come, whether it's natural law or something else. But it seems to me that as a society, I've always been opposed to somehow funding people's health care on the back of car washes and bake sales. That is not an efficient way to deliver health care to people. And as it becomes more expensive, our reports and other reports have talked about increasing burdens on consumers with respect to out-of-pocket costs. I think we're reaching a peak on how much people can actually afford to pay for their health care after they've paid for premiums. But we've got to figure out a way to provide care in this country. I lived in Asia for 9 years. The nice thing about this country is you don't see dead bodies in the street. And the nice thing about the Affordable Care Act, I just reviewed an article for Kaiser Family Foundation. One of the nice things was that we realized after the Affordable Care Act was we didn't have supply shortages as much as everyone thought. All of a sudden you're going to expand care. Many of these people were getting care in this country. They weren't getting a usual source of care. They weren't getting the best care, but they were getting care. And that was a plus that I don't think many people understood. But people, whether it's a right or not, they deserve care in this country, and how we deliver it is an important question.
And there are two reasons, I think. There's an economic reason. You need a healthy population, but there's also a humanity reason. Do we basically say to the 50% of this country that makes $30,000 a year, too bad for you. No health care for you, or substandard health care, or really terrible health care, in fact. And if you get a very expensive disease, you don't get treated.
Well, I think it's a really important question, so thank you for asking it. I also think that if you answer the question that it is a right, it leads you into some very uncomfortable truths about the American healthcare system. My family is from Bartlesville, Oklahoma, and the standard of care my relatives received in Bartlesville, Oklahoma, now that I'm a little more literate, is frankly quite atrocious and medieval. Dallas was better. Baltimore, Maryland, radically better. So when you begin looking at the disparities in health provision and the way in which the country is very uneven, that's why I support so much of what the projects like David Newman are doing, is because it at least raises literacy and information levels about what the expectation level should be across the country. But let's go. Yes, Lindsay. There's our doctor. Hey,
Thank
good
you.
to see you.
Thank
you
you
for
so
still
Stephen
seeing
Pasquin,
human-
Horizon Blue Cross
Yeah.
Blue Shield, and a general internist and an FQHC volunteer.
And thanks
You
for
mentioned
still seeing human beings.
yes, you mentioned Seattle and Salt Lake and Minnesota, and I think that was just for Medicare data. But I'd like to hear from the two of you in a great conversation, by the way, of why you all think that those three areas have more efficient or better health care.
Well, we may have different answers. That'll be interesting.
Yeah, go ahead,
of course.
David.
We've just begun to drill down to the local level. So I don't have a good answer at all. As I said, today was the first time we've done state-level analysis outside of our price transparency.
When you put this report out tomorrow, will it have state data?
No, it's not yet.
Okay.
No, it's all national level.
I see.
Yeah.
So,
I'll say one thing, which is, much like politics, all healthcare markets are local markets. And that used to be a truism among economists, and now what we're realizing is even the local healthcare market is not homogeneous. You've got some providers who have consolidated and can exert market pressure with respect to prices. In Northern Virginia, there's a cardiology group that probably has 250 cardiologists in it, and basically run every cardiology facility in Northern Virginia, and can exert upward pressure on prices. You've got a whole mix of things, and what our work is showing is, it really depends what service you're talking about. There's just one other point I'll make on the Medicare side, and this is, it's just an across the board, again, gets to the utilization issue. When the government has put its thumb down on prices with Medicare, in the subsequent time period, what we see is providers, broadly defined, increasing the rates at which they provide services. There are expectations with respect to revenue, and you have adverse outcomes in terms of, I need to make this amount of money, and if you're not going to allow me to raise the prices, I'll raise utilization. That's the downside to fee-for-service.
Shannon?
From the Medicare data, there's pretty strong evidence that one of the things that happens is this market power of particular providers. And say in Seattle, we have Group Health of Puget Sound. In Northern California, in Oakland in particular, and San Francisco, Kaiser is very powerful. In Salt Lake City, we have Intermountain Healthcare. In parts of Pennsylvania, there's Geisinger. And what these are is they're multi-specialty group practices, and in Minnesota, Mayo has been quite strong. So not only do they have market power, market share, but they also have culture. And their culture actually affects how care is delivered in the wider community. So it's partly the money, but it's also how do the groups of physicians think of what their job is, and how do they organize themselves, and how do they communicate with each other. So those are organized group practices. Most of their physicians are salaried, and they talk to each other. So there are a few common threads in each of these places.
So in a way, you're telling our friends here in New Jersey that they could learn something from the cultural patterns elsewhere.
Huge, yeah, absolutely.
You may. The problem has really been whether those organic organizations that grew in particular locations are replicable.
I see.
Cleveland Clinic tried to open that sort of model in Florida, and the physicians rebelled.
Right.
So it's really
But Mayo did it in Arizona and succeeded.
Yeah,
Part of it is capitalization.
There are questions about how replicable it is.
We could make an NPR show out of the two of you about cars and health or something. One other, right up here in the
There's one
front.
up there, too.
This gentleman.
Hello, I am Eli. I'm a data scientist at a startup, and I'm really impressed by how you've gotten access to such fantastic data sets. It's something I would love to learn how you do. Could you give us any advice on how to get access to such great closed data sets?
Yeah. What was the secret sauce of those?
Well, again, I can't take credit for the decision to do it. I used to jokingly say that the heads of Aetna, Humana, United, and Kaiser probably were sitting at the World Economic Congress in Davos under a big dead animal with a raging fire. And I was at the Arnold Foundation. John and Laura Arnold, John was 39, retired at age 39 with $3.9 billion, and is committed to giving it away, and he funds some of the stuff that we do. And I'm very appreciative. But at the end of the day, I'm at an Arnold Foundation meeting, and Joe Newhouse, who's a noted healthcare economist at Harvard, when I start on that story, he says, interrupts me and says, I was there in Davos. And yes, that's basically how it happened. During the run-up to the Affordable Care Act, and again, up until the time the HCCI was formed, most of what we knew about healthcare in this country was based on the Medicare data. Elliot Fisher and the folks at Dartmouth who create the Dartmouth Atlas are dependent on the Medicare data. And unfortunately, there are not that many live births in the Medicare population.
Or C-sections.
Right, to do a good study of healthcare. So they were insightful enough to decide that it was worth taking the risk to pool the data under the right governance structure to allow us to do a lot of this stuff. And it's not easy. As my chairman, my board says, we hired a New York City Jewish attorney with sharp elbows to deal with the insurers. And that is what it takes to maintain the independence. But we're massively fortunate to have the data to be able to analyze.
And the data are available to other people.
Yeah, we partner with Dartmouth, with Penn, Minnesota, Michigan, Northwestern, MD Anderson, all have licenses to do independent research. And that's the nice thing about the model, is the insurers have agreed to make the data available to independent researchers, as opposed to a model that simply says, we know best, we'll analyze the data that we have, and we'll tell you what is in there. So it allows for a whole bunch of bright people out there to go off and test alternative hypotheses. We're not allowed to sell the data. We're not allowed to commercialize the data.
I just want to put a punctuation point under your comment, because I've done a lot of these forums, and this issue of data and hospital systems, and there's sort of a controversy where many think that some of the stakeholders in the healthcare system hide behind HIPAA for commercial reasons. And so there's a confusion of incentives when it comes to sharing the kinds of data. And I think it's an incredibly important question, incredibly important point, and it's one of the big kind of tectonic, fragile points, I think, in the health system. Let me, just as we close out, we've got our next panel coming up in just a moment. If you were to have a magic wand, and if I were to make you all powerful, Shannon, and we're thinking about the biggest driver today in healthcare costs that you think you could correct, what would you do to turn it around?
Price.
Price.
Wham.
Okay.
If I were queen for a day, the prices would get lowered on a whole lot of stuff. And, we had a conversation earlier. It was very interesting about value-based purchasing.
Right.
And the problem is that the equation for value has price in the equation, and the price does not often have anything to do with the benefit to the patient.
That's tweetable. David?
Yeah, I'd like really good quality measures out there. The discussion, and I don't want to pick on the earlier discussion, but many of those measures that were referred to are really process measures.
Yeah.
Controlling diabetes is an outcome, but many of these things are process measures, and we really don't have good outcome measures. So when we want consumers to consume value, at the end of the day, we drop to price because the quality measures aren't good. And we really need to invest in outcome measures, and they're costly, but that's the only way that you can move the needle.
Ladies and gentlemen, please give a round of applause to David Newman at the HealthCare Cost Institute, Shannon Brownlee of the Lown Institute. Thank you both so much.
Thank you.
Always fun.
Thank you.